Hi, everybody. Thank you for coming. This is Dr. Ed Park, and we're doing a webinar today on tendons. It said that about a third of visits to the doctor for musculoskeletal problems are because of tendons. They tend to be repetitive use injuries, and as we'll learn, the tendons are undergoing constant damage, if you will, and remodeling and repair. We'll get a little bit into that shortly. Tendons are springs. So what we see in kangaroo bouncing is that the spring stretches, it stores that energy, and it gives us a little extra oomph to jump around. Our Achilles tendon is the longest and most powerful tendon, and these tendons are attaching, of course, from muscle to bone. The old adage of use it or lose it comes into play. You really have to use it in order for this tendon to get strong. But then again, if you overuse it and don't allow it sufficient time to repair, then you can get into problems. So it's a kind of a paradox. Um, some of the risk factors for tendon damage include quinolone use, that's Cipro, things like that. Statin drugs, high cholesterol can also be a risk factor for this problem. You can get impingement by fascia and by the bursa, and as well as by bones and bone spurs. And finally, steroids, whether the steroids that are anabolic to make you strong or the steroids that they inject, can cause massive problems with the tendons as well. Other things that cause inflammation can also cause tendon problems. Those include smoking, diabetes, rheumatoid arthritis, obesity, thyroid disorders, gout can also deposit problems into the ligament or the tendons, and aging, of course, is the common denominator. Which is why we talk about the octagon so much. We have depletion of these stem cells throughout our body. If you look above me, there's one disease. In other words, shortening of the telomeres can cause stem cell damage and attrition or depletion all around the body. So in the tendons, like everywhere else, there are stem cells that are recruited to replace the damaged or injured tissue. That slowly deteriorates over time as a result of aging. Okay, as I said, the tendons connect the muscle to the bone. This is not to be confused with ligaments, which, as we see in the upper left, are connecting bone to bone. When we talk about injury, I often misuse these terms, strain and sprain, but actually a good way to remember it would be that T is for tendon. So a strain is what happens to a tendon or muscle. And again, I misuse this all the time. But sprain is what happens to ligaments, and that tends to leave bruising, whereas strains can cause pain and cramping, if you will. Sometimes the bursa are also involved. Those are the little gel packs that cause frictionless lubrication over areas of high friction, such as over bone. And we have to get a little bit into the idea of tendinitis versus tendinosis. Itis just means inflammation, and osis means kind of disease or pathology. So they're both a form of tendinopathy or tendon problems. And sometimes the distinctions can be a little unclear, as we'll get into. But itis is the acute injury. Osis is kind of like a chronic dysfunction, which can be somewhat inflammatory, but we'll get into that a little bit. The balls above me remind us that sports are a common reason for tendon injury. You're exerting muscle, you're accelerating, and you can get these injuries quite often, especially if you do prolonged sports. The graph to my left, or I'm sorry, yeah, to my left on your screen, it shows that if you're blue, it means you're not taking anabolic steroids. If you are taking anabolic steroids that make the muscles, of course, very powerful, then you can get these ruptures. And the graph shows that as you get older, 30, 40, and then 50, about 40% of people will have had a tendon rupture. And that's because the muscles are so massive, and at the tendon, musculotendinous junction, that's where it goes above me from red to white. That's where there's a weakness. So that makes sense. Get older, get stronger. Sometimes the tendons give way. Let's talk about fascia or fascism. If you look on our currency, it harkens back to the Roman Empire. And the Romans used to carry around these fasces. Fasces are bundles of sticks with an axe protruding. And it reminds people that if you're together, you're powerful. One stick is not powerful, but any number of sticks together is powerful. They say the palm trees can bend a lot and they don't break, and that's because they are built up of fibers that are flexible. Whereas the mighty oak can be felled by a storm because it's built for strength and sturdiness. So there is something to be said for that design of having fibers parallel and flexible. It's also been copied by the people who built the Bay Bridge and other suspension bridges. You're not looking at one giant cable, you're actually looking at bundles of cables, which are actually bundles of cables, which are actually fibers. So this is an important model to think about when you think about tendons, how they repair, how they get damaged. This is a cross section to my left of the um, Bay Bridge cable. So how do the cables get made? Well, it's like a liquid glue or a super glue that has a structure. So what happens is that the MSCs, the mesenchymal stem cells, will become fibroblasts. Fibroblasts and tenoblasts are the same thing. They're stem cells that make collagen, yeah? So we have a situation where you need the cells are secreting this collagen and it's self-assembling. It's very interesting. It's self-assembling in a process called nucleation. If you want to know a little bit more about that, you can look at the gout webinar. But everything, these crystals will order themselves. So it squirts out the gel and somehow they find a way to organize themselves into woven fibers like you see above me. And then those fibers will become, the triple helix of the collagen will become a tapestry of fiber, and that'll assemble into these long fibrils, which will become larger fibers, which will bundle up like almost like this garlic clove into bundles, which will comprise your tendon. So there is a higher order of structure that we don't understand. Um, so these assembly into these structures is somehow guided and purposeful, and there is a sort of intelligence involved. It's very important to realize that we need type 1 elastic collagen. That's the springy, strong collagen. When we first get injured, we have type 3, which is a temporary scar tissue type collagen, and that is no good, and that is implicated in tendinosis. So if we look at the diagram or the cartoon above, it basically shows skin healing. But for our purposes, it's the same thing in the tendon. The first of three phases is inflammation. So when the tendon is injured, even though it's not very well vascularized, it can get bleeding into the tendon. That'll cause blood clot formation, inflammatory cascade, meaning white blood cells come in, try and make sure they clear any bacteria. They actually signal a lot of pain, swelling, redness, inflammation, and that's why ice can help initially. Part of that process is that the vessels, which are usually very sealed, can leak serum, and the contents of the serum recruit more stem cells. And those stem cells, in fact, the mesenchymal stem cells are in the blood vessels of every organ in our body. When they sense that there's damage, they will differentiate, they'll copy, and they'll become, in this case, tenocytes or fibroblasts. Same thing. Part of that inflammatory process is also macrophages that come in and attack, gobble up dying and dead cell tissue debris, infection. And then after about 3 days, we transition from this initial inflammatory stage to the next stage. Phase 2 is the reparative proliferative phase, and that's kind of shown in the third of the pictures above me. As that old scar is being healed, the fibroblasts are coming in, they're walling off the area, they're laying down a bunch of type 3, which is disordered scar tissue collagen, as a temporary stopgap. This takes the form of granulation tissue, scar tissue, and in this process there's an invasion of blood vessels and nerves. It's thought that the nerves cause the pain, and that's somehow part of the feedback process of repair. Your tendon hurts because it's already injured. It's warning you, hey, don't injure this anymore. We're still repairing this part of the cable, if you will. Something about tendinosis, which can be considered kind of a diagnosis of exclusion. If it's been 6-8 months and your tendon still hurts, the tendency, no pun intended, is for people to say, this is tendinosis. This is not a normal inflammation, proliferation, and repair. There's something else going on, and some people suggested that perhaps it has to do with the tendon being stuck in this M2 phenotype, which we talked a little about last week with gout. The final phase that we hope to get to is when there's remodeling. So about week 6 to 10, you get the collagen 1 being secreted, and organized into these fibrils. Above me, black and white, are fibrils. That's what we want, a strong, healthy, organized cable. So the pink stuff is that disordered scar-like tissue, type 3 collagen. Over the week 6 to 10, we're trying to get rid of the old scar and lay down strong cable. And after 10 weeks, up to like 6, 7, 8 months, we're still making those fibers stronger by a process called cross-linking. Like fibers next to each other become associated and cross-linked with various chemical bonds. One of the things I learned from listening to and reading about tendon injury is that nobody knows anything. And it's surprising the amount of humility that these experts will say. They're saying, well, I'm studying one part of it, the vascular or the nervous or the biochemical. But everyone's pretty humble about the fact that they don't really understand tendons. Having said that, you look at this flight of birds above, this flock. I don't know if that's real or if it's Photoshop, but it seems to be a flight of birds making a flying bird. And so you don't need to evoke any kind of religion to understand that these birds fly in formation like the blue angels, and they do what they're supposed to do vis-a-vis the birds next to them. And so the healing is an emergent property. You have ongoing inflammation, repair, shift from M1 to M2. You have collagen. Everything's going on at once. These birds don't know how they're making this thing, and these cells don't know how they're making their thing. But the process is ongoing and it's complicated. Part of it, as I said, is that there's nerve invasion. There is central sensitization of pain. There's feedback. That's partly warning. That's partly is part of the repair as well. Vascularization, again, tendons tend not to have a lot of vessels, except in the peritendinous area. And so when you have a tendon that hurts for a long time, it's thought that there's vessels, it's thought that there's nerves in there, it's thought that it's stuck in this sort of M2 phenotype, this granulation repair. It's not going back to that static, elastic type 1 collagen that we need. It's somehow stuck there in tendinosis. So over the long term, what we hope for is as you're using and stretching the tendon, that we'll get a regression of these blood vessels. We'll get a regression of the nerves, and that the type 3 again will be replaced by type 1, which again is from these MSCs. Mesenchymal stem cells are everywhere in your body. They're ready to become liver, become heart, become kidney. In this case, they'll become tendinocytes, and they will secrete the collagen into the extracellular matrix. Okay, so best obviously is prevention. Don't overdo it if you're exercising, stretch beforehand. Pain is a warning sign of impending injury often. The best thing is to exercise where you're sore, but after 24 hours, you're no longer in pain. If you're in pain and you're exercising, there's a good chance that you're going to add injury to injury, and then you are going to have inadequate repair. So stretching is important. Once the injury occurs, of course, we know RICE, which is rest, ice, compression, and elevation. Some people feel that prolonged icing of a sore tendon is not a good idea. Of course, it constricts blood flow, and blood flow is needed for that long-term inflammatory cascade. It might help you with the pain, but it might not help the vascularization and the long-term repair. We want to repair tendons that are completely torn off, because the chance of that reconnecting itself is poor because it constricts or it contracts. So if you ripped it right off the bone, you're probably looking at, once it calms down, a surgical sewing back. It's important, and everyone agrees, that just immobilizing the damaged tendon is not a good idea. You need to actually keep it moving, strengthen it, and stretch it. And what they recommend is eccentric loading. That means using the muscle not as it's shortening, but rather as it's lengthening. That eccentric loading is very important. But you also need fast spring loading to build the muscle and build the power or the strength of the insertion of those fibers into the bone. So the muscular tenderness and the tenderness into the bone are areas of weakness. So you need to have that accelerative jumping force as well. Again, rest not recommended, and the external shockwave therapy has been tried. The literature, the results are unclear whether it's helpful or not. I'll just leave you with this final idea that when you get an ultrasound, and I did this when I did my 2-day course in ultrasound, there was like a 32-year-old young man who looked very healthy, no pain, but even his ultrasound showed degeneration of his tendon. And why is that? Well, you can get ultrasound and extremely sensitive MRIs that show damage to tendon, but the patient isn't feeling bad. They're perfectly healthy. They haven't had a problem for years. It's because you get this donut hole analogy. And this was brought forth in 2016 by Cook. It's a way to say, don't focus on the hole, focus on the donut. So if you make the red donut around stronger, then the hole becomes less significant. So again, radiographic tendinosis does not necessarily correlate with clinical course or behavior. You can imagine looking at the Bay Bridge cable. If you have one section that's knocked out of yellow, but then you make the other sections around it stronger, for all intents and all purposes, you're looking at a stronger cable. So this is the donut theory. If you look at the cartoon to my left, we see a nice drawing, a representation of those ratty, disorganized fibers. It's trying, but it's not quite glistening and white and strong in that way. So that's tendinopathy over the long haul from poor fiber replacement. If we look to my immediate left, you see an actual representation of a damaged lacunae or hole in that tendon. And again, I think I want to draw your attention to the idea that 6 weeks, 12 weeks, even 4 or 5 months out, that's how long it could take to fix a radiographic hole. Although the patient may be doing great by building the donut around, so beware of radiographic diagnoses. So let's go into some of the actual injuries. The Achilles injury is very common, of course, running sports. Men more than women, but women are very athletic as well from age 30 to 49. This tendon is asked to do a lot, and especially if you're doing running or jumping, this is commonly injured. Second one would be the rotator cuff. We did a webinar on shoulder damage, and we see from the side view above me that the rotator cuff tendons come in and they insert on the humerus. Now, this is intra-articular, and so it's said that things that are inside a protected joint space with fluid, they're not as readily able to heal as the Achilles, which is outside the joint capsule. So you can get asymptomatic rupture. I just treated a patient yesterday, or actually, 2 days ago, and she said that hers snapped, a decade ago. And so this is very common as we get older. The incidence, according to this paper cited, is that you have about a quarter of people in their 60s have a complete rupture of one of these inserting tendons, and about half by the time you're 80. Another common injury is the patellar tendon. The patellar tendon, as you recall from our knee webinar, is that quadriceps crossing over the pulley of the kneecap and then inserting on the tibia. This is also known as jumper's knee. It's more common if you're heavier to your jumping weight ratio. People who play basketball, volleyball, susceptible for this. Differential diagnosis in a young person might include Osgood-Schlatters disease, where that patellar ligament forms a bump on the tibia at its point of insertion. We can also have patellofemoral syndrome, which is a dysfunction of the way the patella articulates with the femur. And of course, bursitis, prepatellar bursitis around the area can also mimic jumper's knee. Probably the most common things that people come to the doctor with are golfer and tennis elbow. And those are just irritation of where the tendon inserts on either the lateral, and I also have both of these, the lateral tennis elbow or the medial epicondyle. So the radius is that big bone of the forearm, and if it's lateral, that's from extension of the hand. Okay, so common, you do backhand, that can be overstressed. The medial side is in the golfer's elbow. If the golfer casts, which they really shouldn't, this is caused by flexion of the wrist. Also, the grip contributes a lot. Something you have to grip, like in tennis, can also lead to these problems, especially tennis elbow. So when you have people also doing bicep curls and they curl the wrist, that's poor technique. You're not supposed to do that. That can also add too much stress on that medial condyle. Again, prolonged repetitive motion, especially if you're doing your sport for more than an hour at a time. Or you can have a profession such as plumbers, painters, carpenters, butchers. These repetitive stress injuries can lead to tennis and golfer's elbow. Lastly, the hands are often in use in our modern lives. And so, one very common thing, of course, is the carpal tunnel. As the flexor tendons of the fingers pass under that fibrous ring you see there, that ligament, they can get entrapped. And so, this would cause, if you just tap here to nail sign, you'll get numbness on the first three fingers. The other common one is de Quervain syndrome. That's the extensor pollicis brevis, hitchhiking, and the adductor, and they pass through another little tendon sheath, and they can get entrapped there. Finally, you get trigger finger. Oh, the screen's messing me up. Instead of being smooth, you'll get like a stop and then a snap. Ooh, not smooth, but a stop and a snap. You can see why, because above you see that there is a tendon nodule that gets caught up and then snaps through if it can. Okay, so let's go through some 5 cases of tendon-related injury that were treated with exosomes. Of course, I have to say that exosomes are not FDA approved to treat tendinopathy. It's common sense, I think, that since your body will make mesenchymal stem cells that will secrete their own exosomes, and this is part of our normal repair, I think it's common sense that taking newborn exosomes from MSCs might help boost. But anyway, the first case was a friend of mine in May of last year. She came to see me and she said that she had had injury to her ankle. And so, digging a little deeper and doing the exam, what we really see above is that there's the peroneus brevis and longus responsible for foot eversion and extension of the ankle. So it looked like the peroneus longus was tender in that area. So I injected it with just 1 billion exosomes, and there was some interesting heaviness, inflammation day 8, after which time it didn't hurt anymore. And this was nice because she could again run and train, which she really loved doing. Second case about that time again was May of last year. A gentleman came to see me, and he was just picking up some TA65, I think, and he got IV treatment, but he also, this is the gentleman whose heart rate variability went up 20% after one day of the treatment and remained there. So he was a big time athlete, and he had in this area of the biceps femoris. You could watch the webinar on knee and hip to know more about that. That powerful lateral hamstring was painful over the white area. He had tried all kinds of therapies, alternative things, healing, and none of it worked. So we injected it around a 5 centimeter length with just 1.5 billion exosomes, and it fixed it right up. And albeit this was only a 4-month injury, he could not run, and he was able to get back on the treadmill and run, which was nice. Case 3 is RL. He's 73, very active gentleman, and he had a lot of pain around his patella for about 2 months. He must have injured it doing racket sports. So we gave him 5 billion exosomes around the kneecap in those ligaments where it was painful. Nice thing about these injections, the patient will point to where it's hurt, and you can presume that's the area of tendinosis or unresolved repair or the M2 phenotype or granulation or nerve invasion or whatever. They point to where it hurts, so that's where you put the shot. And so at that time, he also received 5 billion exosomes into the corpora cavernosa of the penis. He had undergone a radical prostatectomy, and that causes a lot of problems, including nerve damage. So he had to actually use an injection to obtain an erection. So he actually wrote back to me a few days ago, and he said that my patellar tendon is much improved. I just came back from running stairs, and he plays tennis 2 hours every other day. He also mentioned that the erectile function is greatly improved, so that's good. Case 4 is KW. This gentleman is 61. He's very active. He works on movie sets, and he did his own research, found me out, and wanted to get something for his plantar fasciitis, which was quite severe. In the diagram or cartoon above, you can see that's about where his pain was. Plantar fasciitis, I think, was contributed by the fact that he had sort of flat feet. So this plantar tendon, or this fascia, is really comprised largely of these flexing tendons of the toes. So what we ended up doing was putting almost 5 billion exosomes into each of the each side of his plantar fascia at 3 sites each. And we also did his ankle. He had a wonky ankle. Knees IV. We did nasal. We did L4 epidural, and we did both shoulders, subacromial bursa. Again, illustrating that, if you come to see me, I'm not going to try and just do one spot. We're going to try and renovate, fix up everything with what you have. And that's my pleasure as well. So it's often that people get 2, 3, 4 injection sites for the same price as one. He wrote back, he said, my knuckle and my ankle are 100% resolved. My feet, they too healed like my back. And he would be all day on them, and they still were healing that plantar fasciitis, stating now that he can walk miles with no problem. So that's a good result. Of course, FDA has not approved these for tendinopathy. Nevertheless, LK is local Hawaiian. She's 56, and she had a nodule, not on her right thumb as above, but her left, right about where that de Quervain's would be. So her thumb extensor tendon and adductor passed under that tunnel, and the bone beneath it, which is, I guess, the radial stylus, or the tip of that long bone, big bone of the arm, uh, was a bump there, a painful bump, and she had that for decades. She thinks it was because she was doing repetitive packaging during bake sales. So we injected it twice, which is a half a cc, 500 million, back in February, and then again in August when I returned. She had her knees done, and she was pretty happy with that. And she stated that it's not red anymore, it's smaller, and it definitely doesn't hurt as it used to. So that's it. It's kind of a short one today. We just talked about tendons, what they're for, what they're made of, how they try and repair it, what happens if they don't. So there are a lot of people who have this sort of nagging tendon pain. Um, my advice would be you got to actually stretch it. Just Google something on YouTube and they'll teach you to stretch it. Even though it hurts, everyone that on the internet, everyone who talks about this says you can't just rest it. You got to kind of stress to the point of pain and stretch it, and that's building the donut around the hole. Um, Based on these anecdotes, it seems that perhaps exosome injections could help with tendon repair. One of the things I learned when I did the 2-day seminar in ultrasound guided joint injections is that sometimes you inject de Quervain or tennis elbow, lateral epicondylitis. There's a known incidence of tendon atrophy. Okay, so uh, the doctors, they use what they can, and the steroids help with the pain, but steroids do destroy collagen. They inhibit the immune response, and they also can poison these fibroblasts. So that's a known complication, and it's pretty horrific to go in there and try and help somebody with their tendon and cause the tendon to atrophy. Known complication, so be careful. Um, Again, thank you for attending. We're just talking about tendons, how they get hurt, and maybe suggesting that a boost to your natural MSC exosomes could be helpful. We don't know. We hope someday that this will be more available and more validated by the FDA. But anyway, that's kind of what I want to tell you about. Next week, I will be doing menopause, a very interesting case of a patient and colleague of mine who began menstruating at the age of 73. So that'll be fun to talk about.